बट सामने रखेड़ा किसी तो भी एक बुक दिए मम्मा
Good evening, everyone, and welcome to today's wonderful session with Dr. Vishnu Soni. And last week, we had a chai pe chircha with Dr. Vishnu, and a lot of clinical points. We have done a wonderful revision. And the way the most recent NEET PG toppers, they think, they remember, they reproduce. No teacher can be able to replace that kind of way to crack the things for the NEET PG entrance. So that is the whole purpose of getting the recent NEET PG toppers to become our teachers and show us the path as to how to become a winner in the tomorrow's NEET PG exam. So with that preamble, let us make the great beginning, Doctor. So good evening, Dr. Vishnu.
Good evening, sir.
So it must be a very hectic day for a surgeon. But thank you very much. With a very short notice, you are able to give your time. So we have almost 10 audience. Can the audience punch whether the voice is loud and clear for all of you? And even the audience, please be very proactive. You know, all these so-called didactic video lectures on the mobile apps, they try to make us very lethargic. Whereas discussion between two clinicians, and that's how we revise the clinical points, is the most interesting to learn for the exam. So let's make the great beginning, Doctor. So let me share. Yes. Great. So today's clinico-pathological review of surgery starts with the first question. So this patient has presented with a lesion which has been shown to you. So how do you approach this case and what is the diagnosis, doctor?
Sir, basically we are seeing women, sir, with breast, and we are seeing that there is no nipple, and the nipple is completely removed or or gone away, wiped off, and leaving a flat, bright red ulcer, sir. So this is nothing short, or you cannot guess anything else. This is Paiges disease of nipple.
Great. So what is the clinical presentation of the Paiges, and can mammogram can help, and what is the age group and few characteristics of Paiges, doctor?
Sir, basically Paiges disease is nothing but it shows that, or it's an indication that there is something wrong inside, or there is an carcinoma inside. It is an superficial manifestation of an internal carcinoma, sir. So whenever you come across such cases, you should suspect there is an internal carcinoma. So the major diagnostic difference or differential diagnosis comes is eczema, sir. You need to differentiate it from eczema, because Paiges disease of nipple presents as irritation, itching, sir. So eczema also has itching. So basic main difference is eczema is bilateral, whereas your Paiges disease is unilateral. Eczema is bilateral and Paiges disease is unilateral. Along with that, nipple is intact in eczema, whereas nipple is eroded or completely wiped off in Paiges disease. So these are symptoms, or these are the things which which you need to evaluate before coming down to the diagnosis.
Great.
And
So,
it is sir.
yeah, yeah. So how do
Sir,
you diagnose and how do you treat?
yes, sir. So when you have come down to the diagnosis of Paiges disease of nipple, now how do you come? How do you prove the diagnosis? You have seen that clinically and come down to the diagnosis. Now, how do you prove pathologically? Is you come down or you do punch biopsy. You do punch biopsy of the lesion and then you find out cells called as Paget cells, which are present in epidermis, Malpighian layer of epidermis, very important for NEET PG entrance. Malpighian layer has Paget cells. And how do you diagnose, or how do you come down to say it as Paget cells? These are large ovoid cell with abundant cytoplasm, pale staining abundant cytoplasm. These are present in Malpighian layer, and thus you come down to diagnosis pathologically as Paiges disease of nipple.
Great. So, how do we treat, doctor? Do we do mastectomy? What type of mastectomy?
Yes, sir. 95% of the times there is an internal carcinoma, sir, and it can be two types, sir. It can be DCIS or it can be invasive. Most of the times, that is 70% of the times, that is DCIS, ductal carcinoma in situ. And so accordingly you deal with as you do with DCIS, that is mastectomy with axillary clearance is done in DCIS, sir.
Great. So typically we do the excision of the nipple and the central ducts if it is localized, and then we do radiotherapy, and mastectomy if it is extensive, which is considered to be the treatment. Now, the second very high-yield topic for the NEET PG exam is the rectal cancer. In fact, rectal cancer is something that as a clinician, almost every week, 1 or 2 cases in the geriatric population, elderly people, we do come across, especially in Hyderabad, where we practice, and at least a lot of my geriatric patients, they come with constipation, anemia, etc., etc. So now let's talk about the rectal cancer. So looking at this specimen, what are your comments on the rectal cancer, and 5 important points people need to remember for the tomorrow's NEET PG?
Yes, sir. So coming down to firstly identifying the specimen, sir. This is a specimen. Basically, on seeing the specimen, you can say it is a large intestine, and downwardly going, it is open, sir. Rectal, it's a rectum. Upwards, it is sigmoid colon and other part of the large colon, sir. So you can come down to diagnosis it as it is a large intestine, showing the bottom part is rectum. Sir, after coming down to rectal cancer, the most important thing you should observe here is the most common site of colorectal cancer is rectum, sir. Including the colon, malignancy most common is seen in rectum. And if they are asking separately in the large intestine, that is ascending colon, transverse colon, and descending colon, then the most common comes down to sigmoid colon. So most common cancer involving colorectal cancer is rectum, and most common cancer in large intestine is sigmoid colon. These are the two basic difference. If they are asking combined colorectal cancer, then the most common is rectum. So overall in large intestine, overall most common rectum, and they are specifically asking you above, then it is sigmoid colon, sir. This is a major thing you should observe first, sir. And then coming down to rectal cancers, colorectal cancer in general are seen more in red meat eating patients, and it is also seen in patients who are having high fat diet. Red meat and high fat diet are risk factors for colorectal cancers. Other points which you need to remember about rectal cancer is, sir, it is seen in elderly patients, and male is affected more than female. These are the things, sir.
Great. So generally rectal bleeding, change in bowel habit, tenesmus, and in about 1/3 of cases, acute large bowel obstruction. And very commonly, elderly person presenting with anemia, 75, 80, etc. I still remember one of my patients, his name is Mr. Swaminathan, a very nice gentleman, and he worked for LIC. So one of the Diwalis, he brought the Life Insurance Corporation diary and came to visit the home and gave a laddu packet and said, Doctor, everything is really going great. I'm touching 79 this year. And I don't know, doctor, constipation, very severe constipation. Throughout the life, I'm a mobile guy, but I don't know, doctor, constipation. I said, constipation. All right, maybe you need to maintain that fiber diet and all that. I was talking. Then he said, 6 kgs, 5 to 6 kgs I lost, doctor. Immediately, that's a red flag sign. So next day morning only, I got a colonoscopy done and found to have rectal cancer. But he is very much determined. He wants to live for his wife. So he already finished 50 years of marriage. Somehow I need to survive the rectal cancer was a strong feeling. But for us to post him for surgery, the challenge was he has ischemic heart disease, coronary artery disease. So he underwent bypass, made him surgically fit, got him operated for the colorectal cancer. Now he is about 86. And every time Diwali comes, he comes with a laddu packet. So that is the reason I always tell that elderly person, constipation means just don't ignore. Any opportunity you need to do a scopy, please do it and evaluate, especially if they have anemia or weight loss, like the red flag signs is what you need to remember. Now, Doc, what are the poor and good prognostic factors?
Sir, I want to add one symptomatic symptoms, one feature, sir. Basically, this is a revision, sir, for all those viewers who are listening here. See, colorectal cancer basically are divided into right and left. Right side you have ascending colon, then left side you have descending colon, sigmoid colon, rectum. So your symptoms are divided into right and left. Sir, excuse me, sir. My battery is running down, sir. I'll
yeah, please rejoin.
Yes,
yeah, no worries. So before Dr. Vishnu rejoins the session, Kamlesh, Bishnoy, and many more who are all online, I hope you're all studying well. And please remember, every day evening, typically we have either a live online broadcast session with the most recent NEET PG Topper joining us, and we have something like a Jugalbandi with them. And otherwise, I'll conduct a quiz program, and the winner gets a 500 rupees cash prize that will stimulate you to fight. Or we will have one of the senior most faculty who is a national faculty or a wonderful, passionate teacher to do a revision for you for about an hour or two. Sometimes even NEET PG toppers will do. Yesterday we had a pediatric class delivered by a NEET PG topper. It was a wonderful class. So I request all of you to be tuned with the YouTube channel, distribute among your friends. Nowhere in the world you get for 1 rupee a NEET PG coaching program, 999 rupees for 3 years. Every day, hundreds of students join, and we feel very happy because otherwise, the NEET PG coaching, the fear of missing out, it's called FOMO. All the commercial coaching centers will say 60,000, 70,000, 80,000, plan A, plan B, blah, blah, blah. You don't need to waste so much of money. What you require is 3 to 4 good friends, few NEET PG toppers who become your teachers and hold your hand and guide you every day. And you require Dr. Murali Bharadwaz. Only 3 things you require to become the NEET PG topper. Let me emphatically tell all of you. So thank you very much, Vishnu, for
Yes, sir.
joining back. Yes, we are talking about the colorectal cancer, right and left. Yes,
Yes,
doctor.
sir. So basically, your colorectal cancer is divided into right and left, sir. Right side you have ascending colon, left side you have descending colon, sigmoid colon, rectum, and anus. So basically, colorectal cancer features are divided right and left, sir. Right side, if at all if there is involvement, you have more of ulcerative lesions. So bleeding PR is more common. Patient presents with anemia, and the obstructive features, which is obstruction or constipation, these symptoms are presenting late in right side, whereas in left side, sir, you have all the constricting lesions. So is the only you have apple core deformity seen due to the constricting lesions in left side. So due to that, most probably you come down, mostly patient comes with a obstruction features, and more than 1/3 of the patient present with obstruction early on, and later on the other feature comes, sir. Other features are painful defecation, that is tenesmus, and you can also see spurious diarrhea, sir. So these are the points which I wanted to add in the symptom points, sir. You can basically on symptom also you can assess or diagnose which side ulcer is there, or which side you have deformity, or which side carcinoma is there. And
Absolutely.
coming down to this question, sir, histopathological feature which shows poor prognosis. Any carcinoma which is involving adjacent organs or involving adjacent uh, structures, that is and poor prognosis, sir. So anywhere any cancer T4 involvement is poor prognosis. Other than that, there are many features, sir. If suppose there is an early involvement of lymph nodes, early involvement of venous or blood involvement, blood spread is early, then that is and bad prognosis, sir. Anywhere poorly differentiated carcinoma is again a poor prognosis. So these are all common points, sir, which say that they have which shows they have poor prognosis.
Good. So wonderful. Now, doctor, this is pseudomembranous colitis with yellow membranes on the large bowel wall. And now, how do you clinically manage a case of pseudomembranous colitis in terms of antibiotics and fluid management?
Sir, I want to add a point on how do you diagnose it, sir. Basically
Yeah.
on features. Sir, this is very tough to diagnose, sir, to anyone, to any NEET PG aspirant. That's a tough to identify the specimen, sir. Sir, specimen slide, sir. Yes, sir. So basically, how do you identify is there is an polyp, sir, polyp-like features, which is there is an inflamed mucosa, and you can also see in between inflamed mucosa, and you can also see yellow color plaques, sir. This is one of the finding you can see in colonoscopy, sir. So there is an inflamed mucosa, nothing but colitis. Colitis inflamed, that is inflammation of colon, and then the pseudomembranous, because there are yellow colored plaques or structures which are surrounding on the wall, which shows as pseudomembrane. So the name pseudomembranous colitis.
Very
Sir,
good.
after diagnosing pseudomembranous colitis, you should know why it occurs, sir. Basically, pseudomembranous colitis occurs due to inadvertent or improper usage of antibiotics, sir. Broad spectrum antibiotics like clindamycin, fluoroquinolones. Due to inadvertent or improper usage of antibiotics, what happens is your normal colon flora, which was normal, which is good bacteria present in your colon, is destroyed or dead, which due to which the causative organism, that is Clostridium difficile. Most of the times your pseudomembranous colitis is caused by Clostridium difficile, because your good bacteria is not there to keep a check on Clostridium difficile. Due to the inadvertent use of antibiotics, your good bacteria dies and Clostridium difficile rises. So these infection occurs, sir. Pseudomembranous colitis occurs majorly due to these things, sir. And coming down to diagnosis, sir. Basically, nowadays the diagnosis is done by ELISA test, sir. What do you now? You can ask me question, ELISA for what? what do you see in ELISA is you see toxins. Clostridium difficile releases two types of toxins, that is toxin A and toxin B. Toxin A, so A and B are released by Clostridium difficile infection. These toxins are released in stool, and on stool you do ELISA test to recognize these toxins. When you recognize these toxins, it's automatically an Clostridium difficile infection, that is pseudomembranous colitis. So you identify it by ELISA test, sir.
Very good. So generally we treat with metronidazole, and we should avoid antiperistaltic agents. And as Dr. Vishnu has rightly said, one of the favorite MCQs in the entrance is, it is the ELISA of the Clostridium difficile toxin B in the stool is considered to be the investigation definitively to make the diagnosis of the pseudomembranous colitis. Then giving vancomycin 125 milligram QID is effective, and sometimes cholestyramine is also given to bind the toxins. And if it is a very fulminant infection, it even mandates surgery. That is, colectomy also is what we need to remember. Now, doctor, this 83-year-old, yeah.
Sir, I want to add one point in pseudomembranous colitis. It's a very important point for NEET PG, sir. Basically, you treat pseudomembranous colitis by metronidazole, sir. Metronidazole oral tablet, that is 250 to 500 mg TID, given for 14 days. This is a basic drug when it is mild to moderate infection of pseudomembranous colitis. When the infection occurs recurrently, then you step on to another drug, that is vancomycin. When there is a recurrence of symptoms or metronidazole is not sufficient, or you see nothing less in symptom by metronidazole, you come down to vancomycin, and vancomycin dose 125 mg QID for 10 days is given, sir. And recent advance for pseudomembranous colitis, sir, there is fecal microbiota transplantation, FMT, fecal microbiota transplantation. This is a recent advance, sir, in pseudomembranous colitis. Probably they can ask in NEET PG. This is a very interesting transplant, sir. You take an feces of some other recipient and transplant it to the patient, sir. So what is the trick here is, you want to transplant the microbia, normal microbia which were absent or which were made absent by inadvertent use of antibiotics. Your normal flora was decreased or made dead. This normal flora is again transplanted through feces, sir. This is a recent advance, sir, and it is very effective, sir. 80% of the times your pseudomembranous colitis can be treated by FMT, sir, but it's not generally practiced due to many other reasons, sir. FMT is a recent advance in pseudomembranous colitis, sir.
So we survive not only by snatching other man's food, we also survive by snatching other man's feces also. So fecal microbiota transplantation. Wow, FMBT. So we should all remember. That's wonderful, doctor. Now, this 83-year-old woman presented with a lump protruding from her anus. So what is the diagnosis? And 3 to 5 points for the NEET PG.
Yes, sir. Basically, this is a very easy question, sir. For anywhere image-based question, anywhere you see mass protruding from the anus, you straight away go with rectal prolapse, sir. Rectal procedentia, rectal prolapse. And here he already mentioned it as 83-year-old women, sir. So basically, rectal prolapse is of two types, sir. Partial prolapse, complete prolapse. Partial prolapse is only mucosa prolapse out of the anus, sir. Rectal mucosa prolapse. Whereas complete prolapse is all the layers, sir. All the layers of rectum prolapse. And partial prolapse is mostly seen in children, sir. So here he have given the age 83-year-old women. So probably it is or it should be complete prolapse, sir.
Wonderful. Very good. So it's a full thickness rectal prolapse. So how do we approach this, and what is important things about its operative management, doctor?
Yes, sir. Basically, seeing in rectal prolapse case, first thing you do is palpate, sir. On first palpation, you can understand if it is a partial prolapse or complete prolapse. If at all in between your fingers you are feeling muscle, that means it is a complete prolapse. All the layers have come down, that is a complete prolapse. So yes, sir, rectal prolapse is as of such a very big topic, sir. But I'll make sure that I'll add on some important points, sir. So basically, rectal prolapse occurs why? Why is the reason? Anywhere prolapse occurs due to high pressure. Pressure differences between outside and inside causes prolapse. So what is the high pressure here, or what is the most common high pressure reason in the rectum is constipation, sir. Maximum 50 to 75% of the patient complains of constipation earlier, before the episode or before the prolapse, they suffer from constipation. So one reason is constipation. Other reasons can be patulous anal sphincter, that means loose anal sphincter, sir. Patulous anal sphincter, then redundant sigmoid colon. Redundant sigmoid colon is your colon is very big, so that it cannot just fit into your abdomen. So redundant sigmoid colon, weak constipation, and weak pelvic floor, sir. Many of them have a weak pelvic floor. These are some of the reasons, sir, of prolapse. Now, how do you investigate? Basically, there must be a thorough clinical examination, and then you should go for investigations. So first you do clinical examination, you feel what it is, and then come down to other features or other diagnostic modalities. So first thing you do is colonoscopy. Now you can ask me, okay, already you are saying outside rectum. Now why colonoscopy? Yes, I have said again, there should be a pressure difference. Some pressure difference should be there, so that there is prolapse. So by colonoscopy, how do you see? What do you do is you see if there is any solid structure or anything which is creating the pressure. It can be tumor, it can be any obstructing feature which is causing high pressure. So by colonoscopy, you avoid that mistake. Many of them, if you don't do, you avoid the major thing. That is, if you are missing sigmoid colon cancer or rectal cancer or some other cancer, how do you treat the patient completely? You cannot treat the prolapse and leave. You need to treat the cause. So basically, first thing you do is colonoscopy to see whether all the above structures are normal or not. To rule out everything, you do colonoscopy first, and then after that, what do you do is normal basic things are not of much use. You check for anorectal physiology. You do a manometry and electromyography of pudendal nerve, sir. Electromyography of pudendal nerve, because pudendal nerve supplies your external anal sphincter. And when your pudendal nerve is damaged due to any reason, it can be trauma, it can be neuropathy, it can be diabetes, it can be immunocompromised patients. Anywhere your pudendal nerve is damaged, your external anal sphincter is gone, and your anal sphincter becomes patulous. This can be the cause of, I have said earlier, it can be the cause of rectal prolapse. So basically, you need to check for pudendal nerve. These are not of much use, sir, but they should be done to rule out. So this is how you work up the patient, sir. And then you come down to a major task, sir. There are more than 50 to 60 surgeries prescribed, sir, for operative management of this thing, sir. But only few are practiced nowadays, sir. Operative management, there can be two types, sir. Perineal approach, abdominal approach. You can approach or you can solve or you can do surgery for rectal prolapse by perineum through bottom only. That is perineum. And abdominal, you open the abdomen, midline abdomen or lower midline incision is given, and you operate on rectum. So two ways you can operate, that is perineal and abdominal. Now in perineal surgeries, what is the major advantage is it's a simple procedure, sir. You don't need to open major big things, or abdomen is not open. So easily done perineal, less time, but major disadvantage is high recurrence rate. You have small area to operate on, so there is a chance of high recurrence rate. Abdominal surgery is it requires a big time, it takes high time, and it is not easy to perform, but advantage is low recurrence rate. So this is how you divide, sir. And one more thing is age factor. See, basically, there is nothing much of thinking in this. If the patient is old, she will not survive a longer time of operation. So basically, what will you choose? Perineal, because it takes less time. So in age-old patients, you go for perineal. So in right now in our case, she is 83-year-old. So obviously, you need to go with perineal operations. What are the perineal operations? There are three named operations, sir: Altimere's, Dillon's, and Thier's anal wiring. These are three procedures perineal. Ultimate is nothing but perineal proctosigmoidectomy. That means your rectum and sigmoid, whichever rectum part is prolapsed, and sigmoid, both are removed in Altimere's, Dillon's, and Thier's anal wiring. These are the three procedures, sir, for
Great.
perineal approach, sir.
Absolutely. So Delorme's is rectal mucosectomy and plication of muscle. And as rightly said, the perineal approach is easy to do, not much of surgical risk to an elderly person, but high recurrence is a very important point. At least for entrance sake, all these proper nouns, Delorme, Altamere, these are the things that we need to remember.
Sir, for
Good.
namesake, sir, for all those viewers' advantages, I said the perineal approach, sir. Again, the abdominal approach are two named procedures, sir: Wells and Ripstein. Wells
Well,
operation and Wells. Yes, sir. Wells operation and Ripstein. Ripstein operation. These are abdominal approaches, sir.
great. That's a very, very important point to remember.
Questions are
Luckily,
asked.
yes, luckily, recent entrance exams are all more focusing on the clinical presentation, what is the next step in the management, more than ripping out the people on Ripstein and Wells or on the Altamere or Delorme, right? Earlier days, even examiners also used to be very obsessive on all this useless proper names, but nowadays it is all more clinical, radiological, and they treat you more like a clinician, like a USMLE Step 3 or a board clearance exam, right? So that's good tendency. Now, there's the CT scan of a 62-year-old man who was admitted to the hospital with the right iliac fossa pain. Right iliac fossa pain. So he was treated conservatively for an appendiceal abscess with antibiotics 6 weeks previously. You call it as Ochsner-Sherrin's regime. So now let us talk about what is diagnosis, differential diagnosis of this clinical scenario, and how do we approach? Yes, doctor.
Yes, sir. So here the CT scan is given of 62-year-old man, sir. Right iliac fossa, he was having right iliac fossa pain, and already in question it is given as treated conservatively for appendicular abscess with antibiotics 6 weeks previously. Sir, so basically after 6 weeks of this thing also there is an right iliac fossa mass. So you can come down to many diagnoses by that, sir. There is a tubular structure there in the right iliac fossa. So a differential diagnosis for this can be mucocele of appendix, sir, acute appendicitis with the luminal dilatation one, and mucinal neoplasm, sir. Appendixal neoplasm can also be diagnosed, sir. Can be kept as differential diagnosis. And other than that is because cecum is nearer to appendix or in the right iliac fossa, you can also doubt it as cecal tumor, sir.
Great. So how do we manage this scenario, doctor?
Yes, sir. Management is likewise, sir. If you see mucocele of appendix, you should, there is a difference depending on the size of the mucocele, sir, and where it is, probably how much it is spread. If it is involving ascending if it is involving cecum, then you need to go with right hemicolectomy, sir. If it is involving your cecum, and if it is basically only the normal acute infection of appendix, then you can leave it off with appendicectomy. So based on the diagnosis, there is a different treatment modalities for them, sir.
Wonderful. Now, what is the diagnosis and what is this surgical gadget that we are using, and few points about this condition.
Yes, sir. So basically, with the image question, you can directly say it as fistula in ano. So this is a fistula in ano, and the probe it's called as Lockhart memory probe.
Right. So, the position of the fistula about Goodsall's rule. So, what is your comment, doctor?
Yes, sir. So basically, fistula in ano again, sir. Why it is occurring? Why should an fistula occur? That's a basic question, sir. Fistula in ano occurs due to previous anorectal abscess which is not properly drained or treated. Anorectal abscess which was not properly treated or drained will lead to formation of fistula. I'm not having digital pen to explain, sir. I could have drawn with diagram and explain, sir. But yes, sir. So why does it occur is due to that previous anorectal abscess, sir. And why that anorectal abscess occurs is due to cryptoglandular theory, sir. At the near to the dentate line, there are glands, crypts of Morgagni. These crypts get infected, sir. These crypts get first infected, then that infection forms an abscess, and that abscess, if it is not properly treated, leads to formation of fistula. So anywhere for the abscess or fistula, same theory, sir, cryptoglandular theory. Your crypts of Morgagni at the dentate line gets infected first. These infection will lead to localized inflammation and abscess formation. And when this abscess is not properly treated or drained, this leads to formation of fistula in ano. That is anal fistula, right? So other than this, other causes can be there, sir, where you see multiple fistulas. It can be Crohn's disease. Crohn's disease, particularly, it is having multiple fistulas, sir. So only we call it that water can perineum. Multiple fistulas are opening through your around the anus, so it is called as water can perineum. It can be Crohn's disease, it can be TB, it can be actinomycosis, it can be any HIV, it can be malignancies, it can be immunocompromised. There are many causes for anal fistula. Primary cause or major cause is cryptoglandular theory. Your glands are getting infected. Other than that, you can go for many things. Right, sir. So basically, there is a Park classification, sir, for types of anal fistula. It is intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. Intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. These are the 4 types of fistula in ano. This classification is given name as Park's classification, sir. P-A-R-K, Park's. Park's, yes, sir. So, small mnemonym to remember it, sir. ITS, it's extra. It's extra, sir. ITS, extra. It's extra, they say, sir.
It's extra, okay.
Yes, sir. Intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. These are the 4 types of divisions in fistula in ano. And majorly now cases, everyone is facing clinical questions more, sir. They say high-lying fistula, low-lying fistula. Now, what is the dividing line or dividing structure by which they say high or low is anorectal region, sir, anorectal angle. This anorectal, above this anorectal, that is high lying. Below anorectal, it is low lying. So this anorectal region, above is high lying, below is low lying, sir. Now, how do you diagnose? If a fistula case comes, how do you diagnose? First you do is fistulogram, basic thing, fistulogram. Then gold standard or more accurate is MR fistulogram. By this you can say exactly the position where it is, whether it is high lying, low lying, all tract, size of the tract, everything can be known by MR fistulogram. Coming down to treatment of fistula, sir. there can be three things done: fistulotomy, fistulectomy, and setons. Fistulotomy, otomy, anything otomy is opening up. You do nothing. You pass a probe through the fistula, you open up. So this is fistula, sir. For example, if this is fistula, fistulotomy is nothing but you open it up, sir. You open it up. This was the fistula. You just open it up. This is fistulotomy. And fistulectomy is nothing but you completely remove the tract. This was the tract, you completely remove it. Fistulectomy. Fistulotomy is just opening incision on the fistula tract and you keep it open. That is fistulotomy. Fistulectomy is complete removal of the tract. And seton. Seton is nothing but they call it as Sharasutra, sir. That's a thread, nylon or silk thread, which is passed through the probe. Fistula is having external opening, internal opening. So a thread is passed from external to internal and it is tied. So your high-lying fistula comes down slowly within days and becomes low-lying fistula. And after it is becoming low-lying fistula, you can treat it as fistulectomy or fistulotomy, depending on where it is located. So this is the thing with fistula, sir. Fistulotomy, fistulectomy, seton. Seton is used when it is high-lying and you make it as low-lying. This was all about fistula, sir. And you asked me about Goodsall's rule, sir. Goodsall rule is very important. Any viewer who is UG here doing his UG final year, it's a very important 2-mark question. Compulsorily they'll ask Goodsall's rule. Goodsall's rule is nothing but your anal canal is divided into anterior and posterior. Anywhere fistula external opening is present anterior, on the anterior side of the anal opening, they have straight tract. And wherever if the opening at the external opening is present posterior side of the anal opening, then they have curvilinear tracts and they are opening in the posterior midline. So you always remember Goodsall's rule is nothing but you should remember where the external opening is. If the external opening is on anterior side of the anal canal, anal opening, then it has straight tract. And if it is in the posterior side of the anal canal, posterior side of the opening, then it has curvilinear tract, opening into the posterior midline.
Absolutely. So almost we covered most of the aspects of the fistula in ano, and tomorrow NEET PG exam. I'm very sure for the audience, when they get a question on fistula and ano, this evening will be memorable. And if your concepts are clear, you don't need a revision, honestly. A lot of people will be worrying, oh my God, I forgot to do that breast carcinoma topic revision. Don't expect tomorrow exists in our life. Think that it is the last day of the life. So first to take only, you need to know to catch the concepts and some method to remember them, and that is the best way, that you need not worry about revising tomorrow. So you so clearly explained and made us understand, doctor, that even in we close eyes, we can be able to tell 10 common points about the fistula in ano. The parts classification and Lockhart memory probe, then Goodsall's rule, the crypts of Murgali, water tank perineum, etc., and its extra, that is intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. That's how we classify the entire story into. And if it is typically fistulotomy, when we will do fistulectomy, when we will do seton. That is most important thing to be remembered. Wonderful. Now, what is the diagnosis and what 3 to 4 points about this, doctor?
Yes, sir. Sir, basically, it is an anal fissure, sir. You can see a cut in the anterior part of, in this image, you can see anterior side, there is a cut in the anal mucosa, sir. So by this you can diagnose it as anal fissure, sir. Nothing but anal fissure is nothing but there is a discontinuity in anal epidermis, or anywhere there is a discontinuity or cut or ulcer in the anal epidermis or anoderm. That is an anal fissure, sir. Basically, anal fissures are two types, sir: acute and chronic. How do you diagnose, or how do you come to the diagnosis of chronic anal fissure? Is there is always an uh, uh, piloneedle or one patch of skin which is coming down from the fissure, sir. That patch of the skin should be seen, sir. Probably in this image it's not seen, sir. One
Yes, the
patch of
anal tags and the anal tags are a important indicator of a underlying very high pressure zone in the underlying chronic anal fissure. Sentinel feature.
pile, sentinel pile, sir. Yes, sir.
Right. So,
So
and in
with
fact,
chronic thing, yes, sir.
yeah, in
With
fact, chronic anal fissure, once more, I always encourage people to do MD general medicine, because if you become, if you read all this stupid crap for the entrance exam, ultimately you became dermatologist. You can't use anything anywhere except psoriasis and pemphigus vulgaris. Then as you become physician, you advise the pregnant women, you advise the pediatric, you advise psychiatric, you advise geriatric, you advise everything. At least I have about around, I can say, 20 chronic patients of anal fissure regularly visit me once in 3 to 4 months. I had been, they had been my patients for years together. You know, one of the patients used to say, why this fissure come, when this fissure come, how that fissure goes away, I don't know. At the most unexpected times, morning when I woke up, the problem starts. And when I was expecting it, I don't care about it, that time it is disappearing. So mainly it is a problem of constipation leading to hard stool cutting through, and that makes the sphincter become more tighter, and further that will worsen the expression of the next stool, and for that he need to exert more pressure and more amount of fissure happening unless we break that cycle. So that is all miserable thing, like varicose veins, anal fissures. They won't kill you, they won't let you to live happily. That is the unfortunate thing. Yes, doctor.
Sir, you have with just by saying a narration or story, you have explained everything about anal fissure, sir. Basically, anal fissure is a cut in the anoderm, sir, and why it occurs is due to main first reason is constipation, sir. Due to the hard stool which passes through your anus. If this is anus, and it passes, your stool passes hard stool, so your anoderm gets cut here, sir. So basically there is small concept, or you don't need to memorize this. Most common site of anal fissure is posterior, because when you squat, your stool causes more pressure on the posterior side and it rubs there. So most common site of your anal fissure is posterior side. Posterior side of the anal canal will have anal fissure. Anterior anal fissure is second most common. It occurs during normal delivery of babies. It occurs in women. So posterior is most common. Second most common is anterior. You can also have lateral. You can also have multiple. This is the foremost reason, sir, of anal fissure is constipation. And after that, what happens is presenting feature is painful bleeding through PR. Painful bleeding occurs, sir, and he also complains of constipation. Why constipation? There is no cause, or there is a reason, that because if he is squatting or if he is going for a passage of stool, it is paining and he'll avoid passing stool. That will lead to constipation. So constipation is and reason or because of this painful bleeding. These are the two presenting features: painful bleeding, constipation. Now, how do you approach acute anal fissures is, or chronic anal fissure is, basically first thing you do is this is a type of ischemic ulcer. Remember, this is a type of ischemic ulcer. So what you should do is increase the blood supply. How do you increase the blood supply? By decreasing the pressure. How do you decrease the pressure? By giving laxatives. First thing you do is laxatives. Sir, before going to treatment, one major important and many a small logic, sir. How do you diagnose anal fissure? Is a question, sir. Mostly they'll ask in vivas, sir. If you never do per rectal examination, PR is contraindicated in acute anal fissure. Why? Because it is a highly painful condition. You cannot pass even the little finger. So PR is contraindicated in acute anal fissure. How do you diagnose then? You diagnose it by clinical examination. Just by inspection, you identify that it is an anal fissure. Right. Now coming down to the treatment, first thing you do is application of laxative. You give laxative because you want to decrease the pressure. You want to treat the constipation. You give laxatives and then you give topical application of local anesthesia, sir. Local anesthetic agents are given, and also you can try, these days they are trying diltiazem and nitrite, sir.
Yes, diltiazem and nitrates, absolutely.
Yes, sir. So they are nice, sir. Previous slide, sir.
Yeah.
Yes, sir. So they are giving diltiazem and nitrates. These are the recent treatment. Other than that, you can go with sitz bath, topical ointments, and also by changing diet. These are the few things which you do, sir. After this treatment also, if the patient is not cooperating or if it is not decreasing, then you go for lateral sphinctrotomy. Why not anterior, why not posterior is a major question, sir. They can ask, why not anterior? Because if you anteriorly cut the sphincter, anterior is roof. If you cut the roof, what is above? It is vagina, or it is prostate in males, vagina in females. You can injure those organs. Why not posterior? Because if you create in the posterior, you can create an defect where you can form an abscess or something. Lateral is safe zone. So not anterior, not posterior, you go lateral sphincterotomy. Now what sphincter you cut here? External or internal? It is internal sphincter, because if you cut external sphincter, there is anal incontinence. Patient will sue you. Patient will not forget us, sir. If we cut external sphincter, that will lead to anal incontinence and will come again and again to us. So internal sphincter, you cut mucosa, you slowly go through the muscles, you see the pearly white circumferential muscle, that muscle is only cut. That is an internal sphincter. So that is a lateral sphincterotomy, sir. Why do you do lateral sphincterotomy, sir? Nothing, sir. Basically, the muscle is taut there, sir. The muscle is taut, and due to this taut muscle, your fissure or your cut is not getting blood supply. If it is not getting blood supply, if you cut a sphincter, muscle will relax and this ulcer will have blood supply. So only indication for lateral sphincterotomy is to reach the blood supply to the ulcer zone. I have earlier said it is an ischemic ulcer. So if you cut the muscle, taut muscle, the sphincter will relax and the blood supply will reach the ulcer zone. So your ulcer will heal. Patient will appreciate that, sir.
Absolutely. Wonderful point, doctor. Why lateral sphincterotomy? Why not anterior and why not posterior? A very good explanation. In fact, that anterior will damage the roof and vagina and prostate can get exposed. That's a wonderful point. Now, doctor, this is a 4 to 5 centimeter diameter right posterior perianal ulcer, which is extending into the anal canal with the raised edges which are everted. So, what are the comments and how do we approach?
Yes, sir. Sir, it's given in explanation only, sir. It's an 4 to 5 centimeter diameter posterior perianal ulcer. Edges are raised and everted. These things only should come down to diagnose it as squamous cell carcinoma, sir. This is an squamous cell carcinoma, SCC, of anal canal, sir. These are basically anal canal cancer, anal canal carcinoma, which has spread down to external or remaining out comes out of the anus and is infecting perianal region. Yes, sir. Because it has spread, sir. It's an and the most important NEET PG point here is, sir, most common variant of anal canal carcinoma is SCC. Squamous cell carcinoma is most common type of carcinoma of anal cancer.
Wonderful. In fact, HIV and renal transplant patients on interferon therapy are very commonly seen by the nephrologists, referring the anal cancer patients to the surgeons, and even perianal warts and leukoplakia and fistulae are considered to be predisposing factor. So, Negro regime is, are we still using this, doctor?
Yes, sir. We are still using it, sir. The how do you diagnose it as ulcer? You need to go for cytology, sir. Cytology of that ulcer and also punch biopsy, sir. By this, you can come down to diagnose it as cancer, carcinoma. And after coming down to carcinoma, you do what you do is to see the stage the cancer. You go for PET scan or MRI, sir. Treatment is Negro regimen, sir. Negro regimen is nothing but chemoradiation, chemotherapy plus radiation, radiation therapy. This is a treatment. Chemotherapy is 5-FU plus mitomycin and radiation. Chemotherapy plus radiation. Chemotherapy is 5-FU plus mitomycin. What happens is, if after this treatment, if it is resolved, or if your anal cancer is decreasing or resolving, then it is well and good, sir. You continue with the the same treatment. And if it is not resolving or if recurrence occur, then you go with APR, sir. Abdominal perineal resection. Negro regimen, APR. These are two modalities of carcinoma anal cancer, sir. Carcinoma anal canal.
That's wonderful. Now, this 63-year-old male patient presented with vomiting, central abdominal pain, and distension. So, what is the diagnosis and how do you approach?
Yes, sir. This was the last image. When I took the last class, this was the image-based question, sir. So, all the viewers or whoever watching this should remember that you should see erect abdomen and diagnose it as which type of obstruction it is. So, in this particular type of X-ray, you see valvulae convenientis. So, valvulae convenientis is diagnostic feature or is an anatomical feature of jejunum. So, there is a dilatation of jejunum or small intestine. That means it is a small intestine obstruction. And basically going on to the image based, other than that, there is all presenting features, the same thing, sir. Vomiting, central abdominal pain, distension. These are all features of small bowel obstruction.
And commonly it is the past surgery, that is the adhesions, most important cause.
Yes, sir.
And of course, there is a very big plethoric list of causes of this small bowel obstruction. Yes. And yes. Now, you have any comment on any of these three important comments on small bowel obstruction, doctor?
Yes, sir. So basically, small bowel obstruction, you should decide on basic how the patient is, sir. Based on his clinical examination, based on his evaluation of diagnostic evaluation, all his blood markers. Based on these things, how severe is the patient? Based on that thing, you decide if you can go on operative basis or you can still wait for non-operative management. So this depends on patient, sir.
Right. So, and another thing is to decrease the adhesions, hyaluronic acid carboxymethyl cellulose membrane is the one which is being used, which decreases the chance of small bowel obstruction post-operatively. Yes. Now, this 44-year-old male presented with intermittent abdominal pain, and the CT scan has shown small bowel obstruction with intussusception, and when he was being operated, this is what being found. So what are your comments on this surgical specimen, doctor?
Sir, the straight away point, sir, there is nothing to discuss on this, sir. Image-based direct answer is Meckel's diverticulum, sir.
Absolutely. So what is the rule of twos in Meckel's diverticulum?
Yes, sir. It's an most common congenital tract malformation occurring in 2% of the population, sir. It is seen in 2 feet from the ileocecal junction, that is 60 centimeters from the ileocecal junction. It is in 2 inches long, and it is commonly contains two types of epithelium, and it is less than 2%. It's symptomatic in less than 2 years of age, sir. So these are rule of two, sir.
Great. And generally, it is the vitalointestinal tract that obliterates between 5th to 7th week of gestation is what we need to remember. And how do we make a diagnosis of this? This came up as a intraoperative finding, but preoperatively, what is the means of diagnosis, doctor?
Yes, sir. So Meckel's diverticulum basically occurs in early age, sir. In children, they see, sir, and they majorly present as bleeding. Why bleeding occur is a major question, sir. Again, there is a small concept that the ectopic mucosa, there is an ectopic mucosa present in Meckel's diverticulum. This is an vitalointestinal duct which is not made absent, sir. Generally, it gets dissolved, but undissolved vitalointestinal duct is Meckel's diverticulum. So in this Meckel's diverticulum, you have ectopic mucosa of stomach, ectopic mucosa of pancreas, and ectopic mucosa of colon. There can be 3 mucosas in this. Most commonly it is stomach, sir. So due to stomach mucosa, there can be ulcers in this Meckel's diverticulum, and those ulcers bleed. So that is the main reason of bleeding. Hemorrhage in Meckel's diverticulum is due to ectopic mucosa of stomach. Other than that, other than this presenting feature, you can also have small bowel obstruction. Why? Because this Meckel's diverticulum can act as lead in forming intussusception. This can act as lead in intussusception and also can act as volvulus. It can take a lead due to adhesion to the abdominal wall. It can rotate the intestine. So they can present as small bowel obstruction. That is, it can be volvulus or intussusception. They can present as hemorrhage.
Wonderful. And it is the technician per technique scan.
Yes, sir. Yes, sir. Your question: how do you diagnose it? How do you diagnose if at all in children is bleeding PR? First thing you do is technetium 99 per technique scan. By
Absolutely.
this, what happens is it diagnoses ectopic mucosa. So by this, you can know where the problem is. Technetium 99 per technique scan detects your ectopic mucosa, and by that you can diagnose it as Meckel's diverticulum, sir.
And if it is symptomatic, we do the small bowel resection.
Yes,
and,
sir.
Yes. And if asymptomatic or incidental finding, it depends upon whether there is a high risk or not. That is a deciding factor. So, what are the scenarios, even if asymptomatic, but if the patient is being found coincidentally Meckel's while you are doing laparotomy? When do you operate, doctor?
Sir, basically, you divide it as symptomatic and asymptomatic, sir. Symptomatic will deal first, sir. You can do diverticulectomy. Whole diverticulum is removed. Meckel's diverticulum is removed. You can also do resection and anastomosis. There are 2 modalities in children where you have symptomatic cases of Meckel's diverticulum. You can go with diverticulectomy. You can go with resection and anastomosis. Mostly nowadays they are going with resection and anastomosis, sir. Diverticulectomy is done when the base of the Meckel's diverticulum is fine, sir. There is no incarceration or there is no features of strangulation. Then you can go for diverticulectomy. Only diverticulum is removed, but you go with resection and anastomosis because if at all, if this is if here it is diverticulum, sir, you remove this involved part, sir, this part of the small intestine also along with diverticulum. Why? Because your surrounded mucosa here near the base of the this is diverticulum. Imagine this is diverticulum. You remove till here. Both small intestine, both sides small intestine is removed. Diverticulum is also removed because at the base of the diverticulum, surrounding to the small intestine mucosa, also there is ectopic mucosa. Even if you do diverticulectomy, that mucosa is remaining and the patient will still complain. So Resection and anastomosis is majorly done now, sir. Diverticulectomy is not done. This is about symptomatic, sir. Asymptomatic thing is, while doing other surgeries, simply if you check for 2 feet, sir, simply you check for 60 centimeters of small intestine. If at all, if you come across Meckel's diverticulum, nowadays it is indicated, sir. It is given in SABI standard. Around 6.4% of the complications are there if you don't remove Meckel's diverticulum. Even if the patient is symptomatic or asymptomatic, irrespective of his age, you do resection and anastomosis, you remove Meckel's diverticulum, because there is a high chance of complication later on in the life. So anywhere patient up to 85 years, you go with resection and anastomosis. If at all, if our doctor's fate is very good, if the patient is above 85, then you can still think of leaving it alone, sir, because probably patient will not survive more.
Sure. Absolutely. So they are the important point. So wonderful, doctor. Today we had a feast of learning, and Supraja Reddy and B Reddy Supraja, Avanti, Kamlesh, and many more who have joined Chai Pe Charcha with Dr. Vishnu Soni. Every week you should give an hour of audience and inspire the NEET PG aspirants to take up surgery as their favorite branch by the inspiration from Dr. Vishnu. So thank you very much to everybody for joining this wonderful evening.
Sir, I need to add one point, sir, to all the viewers, to all NEET PG aspirants. Basically, thing is, sir, there's not much of thing in cracking NEET PG, sir. There is no big deal, sir. Only small logic. No one will say this, sir. No coaching center will say, no topper will say, or nothing it's given in books. It's all of mindset, sir. Mindset is you need to keep yourself happy. Happiness is in the center, sir. Around everything is in the circle. So when you keep yourself happy, now how do you keep yourself happy? When you reach your goals. When will you reach your goals? When you keep yourself small goals. Every day keep yourself small goals. And when you keep smashing them, you'll be happy. You again keep goals. You reach them, you'll be happy. So this is a cycle, sir. Basically, keep yourself happy, set yourself small goals. That's the only small trick I want to say to everyone, sir.
Absolutely, that's a very important point. To be happy is something nowadays. I'm practicing a very good thing called intermittent fasting for the past 1 week, and it is really working great. Intermittent fasting means I skip the breakfast. I don't take the breakfast. Straight away, 1 o'clock, I take the meal. Then once more, I take it 8 p.m. in the evening. So from 8 p.m. in the evening till next day morning, afternoon, 1 o'clock, I don't eat anything. So almost all 17 hours of fasting we are giving, and that is shifting suddenly the entire digestive system. From consuming carbohydrates, it is moving it towards consuming the fat. And Langanam Paramaushadam is one of the oldest adage. Langanam Paramaushadam. Actually, what happens in residency is, I still remember 36 hours night duty. Even forgetting that we have taken the lunch, we were seeing the patients until the sugars came down to 60. Almost about to faint, and somebody said, "Arey, you skipped the food." But once you get married, you are surrounded with a lot of love, and people will be feeding you through rice sugar to eat. And your mouth becomes like a tube, eat kind of thing. So, but this intermittent fasting, recently NEJM also published the advantages of intermittent fasting on losing weight and giving chance for the body to repair the cellular aging and the pre-oncogenic tendencies. So, as you rightly said, by eating less, and to giving rest to mouth from 8 p.m. till next day 1 o'clock, there is a real happiness. So I always, and evening, I stopped working at 5 o'clock and started playing cricket with all my kids and kids' friends, gully cricket, and almost sweating out 1.5 hours in cricket or in playing football is the best way that life can be made easier. And only when we are happy, I fully agree with you, Dr. Vishnu. Only when we are fully happy and small goals improving every day, that will make us stronger and stronger, and we realize our dream. So thank you very much for this wonderful evening, and we will once more meet tomorrow. Good night.
Thank you, sir.